everyone. Welcome to Radiology Case Videos. Today we have an interesting case to discuss, which is that of Ovarian Hyperstimulation Syndrome. So we'll begin with a lineup of ultrasound images of the case, followed by a brief theoretical discussion. So here we see a sagittal ultrasound imaging of the right kidney. The kidney appears to be of normal renal dimension, echogenicity, and location, with no renal cysts or hydronephrosis. We can see fluid in the hepatorenal pouch. There's no increased echogenicity of the liver. The liver surface appears to be smooth. Here, we are seeing a set of ultrasound images of the right and left ovaries that are near symmetrically bulky. The largest dimension of the right ovary is about 9.5 centimeters, and of the left ovary is about 8 centimeters. We can also observe multiple small cystic follicles of varying sizes, giving a spoke wheel appearance. We can also note some pelvic adnexal fluid. So this is the uterus with no obvious uterine anomaly. The endometrial thickness is within normal limits. There's mild pelvic fluid in the pouch of Douglas. So we have just seen images of a case of OHSS, Ovarian Hyperstimulation Syndrome. It consists of ovarian enlargement with extravascular accumulation of fluid leading to a variable weight gain, ascites, pleural effusion, intravascular volume depletion, and oliguria. Imaging findings tend to be similar on ultrasound, CT, and MRI. To summarize the radiographic findings, typically shows bilateral, symmetric enlargement of ovaries, often more than 12 centimeters in size. Multiple cysts of varying sizes are noted in both the ovaries, giving the classic spoke wheel appearance. Associated findings of ascites and pleural bar pericardial effusion can be noted. The syndrome is relatively common, occurring in 5% of patients undergoing in vitro fertilization or IVF. There's probably an even higher incidence of the syndrome in egg donors due to their young age. So a few of the risk factors for OHSS are high baseline ovarian volume, background polycystic ovaries, low body weight, long ovulation induction cycle duration. The clinical picture may vary from abdominal distension and discomfort to potentially life-threatening capillary leak with fluid sequestration in a third space and massive ovarian enlargement. Pain, abdominal distension, nausea, and vomiting are frequently seen as symptoms. So OHSS is characterized by massive cystic ovarian enlargement and fluid shift from the intravascular compartment into the peritoneal, pleural, and pericardial spaces. The vascular fluid leakage is thought to result from an increased capillary permeability of mesothelial surfaces under the action of one or several vasoactive ovarian factors produced by multiple corpora lutea. Acute pelvic pain may result from stretching of the ovarian capsule or hemorrhage or rupture of the follicle. Coming to the complications. Tissue edema leads to ascites and hydrothorax, eventually leading to compartment syndrome. Hypovolemia would cause decreased organ perfusion, leading to liver and renal impairment. There would be hemoconcentration and hypercoagulability, leading to thromboembolic events like stroke. Now in OHSS, serum estradiol E2 levels are elevated. Can OHSS be spontaneous? The answer is yes. This subtype occurs in the absence of any external stimulation. This form can occur in pregnancy, including molar pregnancies. There are also very rare sporadic forms which carry a genetic component. These have an association with early pubertal development and primary hypothyroidism, which is Van Wyck-Grumbach syndrome. Ovarian stimulation in the hypothyroid child may result in estrogen production, breast development, endometrial proliferation, and vaginal bleeding. So, it is likely that raised TSH concentrations bind and stimulate the FSH receptor, although a similar overlap phenomena might occur at the level of pituitary, with enhanced TRH production stimulating the GnRH receptor, with subsequent ovarian enlargement. The cystic ovarian enlargement resolves with thyroid hormone replacement. A hyperstimulation phenomena in patients with an abnormal FSH receptor has also been described. So this is the Golan et al. Classification of OHSS into mild, moderate, and severe. Now, our case falls radiologically into moderate severity with an ovarian size between 8 to 12 centimeters and presence of ascites. This can be conservatively managed at home. Now coming to the differential diagnosis of OHSS, first is polycystic ovaries. So what are the radiology features in polycystic ovaries? We see increased follicle number per ovary. That is, the FNPO is usually more than equal to 20. Individual follicles are generally similar in size and they measure around 2 to 9 mm in diameter. There's a peripheral distribution of follicles giving a string of pearls appearance. There's background ovarian enlargement where the volume is greater than 10 ml. The central stroma is bright and prominent. But like in OHSS, we do not see third space fluid loss in polycystic ovaries. But polycystic ovaries is definitely a predisposing factor for OHSS. Next is theca lutein cyst. They have a very strong association with gestational trophoblastic disease and also with multifetal pregnancy and diabetes. So these cysts are usually very large, 2 to 3 centimeters, and the ovaries often have a typical multilocular cystic appearance across all the imaging techniques. So ultrasound shows bilateral enlarged multicystic ovaries. The cysts are classically thin-walled and they are very clear contents. There's large amount of solid component, which is possibly the residual ovarian stroma. The next differential is a mucinous ovarian neoplasm. So neoplasms naturally would have a more obvious solid component present. Also, the ovarian tumor markers or the beta HCG levels can be elevated. So the OHSS syndrome is usually self-limiting in most cases, and management is mainly supportive. However, cases with a fatal outcome have also been reported. So severe cases usually require hospitalization and close monitoring of hematocrit, liver function, renal function, serum electrolytes, and oxygen saturation. The profoundly altered maternal environment of OHSS is a significant risk factor for miscarriage, especially when occurring in the early phase of IVF, defined as less than 10 days after oocyte retrieval. That brings us to the end of the discussion on OHSS. If you wish to see more of great radiology content in a nutshell, do subscribe to the channel. Thank you so much for watching.